Dr. Stephanie Ramdas is in clinical practice in Toronto, Ontario, Canada. She graduated from the Inter-American University of Puerto Rico School of Optometry and completed a cornea and contact lens residency at the Michigan College of Optometry. She is a member of the Ontario Association of Optometrists and a fellow of the American Academy of Optometry and a fellow of the Scleral Lens Education Society. She is a contributing author editor for the Contact Lens Spectrum and Clinical and Refractive Optometry, and a committee member and contributing author for the International Myopia Institute. Dr. Patricia Flores received her Doctor of Optics, Optometry, and Vision from the Complutense University of Madrid, Spain. She has a master's in optics, optometry, and vision from the Complutense University of Madrid, Spain. She has a diploma in optics and optometry from the Complutense University of Madrid, Spain. She's an optician by the PUC de Valparaiso and a medical technologist mention of ophthalmology from the University of Chile. She is a fellow of the Scleral Lens Education Society and an International Association of Contact Lens Educators member. She specializes in the adaptation of contact lenses and diseases of the ocular surface. And Dr. Flores conducts conferences and publications in the area of optometry and specialty contact lenses. She is currently the Latin American professional educator for Menicon and the CEO of Patricia Flores Vision Center. Please welcome Drs. Patricia Flores and Dr. Ramdas.
Hello, everybody. Good morning here in Canada. And I know we're in different time zones here, which really you can feel kind of the power of this type of event. I do want to thank Mindy and Daddy for reaching out, and to the Summit of Specialty Contact Lenses for having us. And I can speak on behalf of Patricia and I that we are elated to be the last one for this fall series. So I hope you guys enjoy the presentation. So we're going to be talking about the various uses of corneal topography today, and we really want to get into some of the clinical specifications on how you can go into practice and maybe take in a few pearls that you can put into go back to clinic. So we can get next slide. We're just going to go over the agenda really quickly. And so the purpose for today is to understand why we're really doing topography, what it means to take a topography itself. We'll go over the different types of instrumentations that you can use, as well as how to really optimize to get the ideal fit. So that way the information you're gathering is the best captures that you can have. As well, we'll talk about how you can use different applications of the topographer system and look at different types of contact lens modalities, and how you can best use the unit to optimize that particular type of fit. And so if we can get into the next slide, we'll start off right away when we think about why we are looking at corneal power and shape. Why is it important? When we look at just, if you think about yourself oculars of a slit lamp and you are scanning, you typically have your optic section. Let's say you don't have the pupils wide open, the aperture wide open yet, and you're scanning across the central portion of the cornea, you're really not gathering much information. If you go ahead and take a topography of the patient's eye, if we go with the next unit, you can see that it can be a drastic difference, even though the central portion of a cornea can be very similar. And this is very similar to the information that we'll get from, let's say, the keratograph or an autorefractor reading of keratometric readings, which are effectively, if you think of it, just your flat K and your steep K. And in this case, there's a drastic difference. The story is very different when we take a topography between these two different eyes. If we go to the next slide, we were looking at axial maps prior in a topographer unit. This is a video here of an elevation map. And so it's for that same eye that you saw with that 22 diopter of corneal against the rule of astigmatism. And so with an elevation map, which is different units have different ability to do this aspect of software, you can see that if we go from the different meridians of elevation, we're changing. You may not be able to see the small numbers, but you're effectively going from the steepest to the flattest portions of the eye, or the highest to the lowest portions in the corneal surface. There's a 600 micron difference in that particular eye. So if you didn't use topography, you wouldn't have known that. You may have been able to appreciate that from the slit lamp and just using the oculars behind when you're at the slit lamp, but you won't really be able to gain a better understanding of what is going on with that cornea. So that's the reason it's important to look at maps that are provided in your corneal software, your topographer software. And so we'll use different maps today to discuss some of the clinical applications as we go through. If we can get next slide. The question arises then, how do you take a topographer? What instrument are you using? The keratometer is really just getting us that central bit of information that I mentioned to you before, but we can tell that that obviously does not give us, fine, okay, our Myers could look skewed in a keratograph, and in the keratometer, if anyone's pulled that out recently. I know it's been a while since I've used mine. And so you can get an idea of irregularity based on the reflections when you're looking at keratometry. But really, it's the topography that's going to give us a better idea. You can have what is imaged here is the placido disc topography, where we're looking at effectively the reflections off we're gathering information about the cornea off of reflections of the tear layer. And we'll talk about how to optimize those types of acquisitions. You can see here, you can have various units where you can have a large wide-shaped dome, or you can have the small type of aperture in order for gathering information. And both of those can be very useful. You can also have shine flue topography. You can have scanning slit topography. A lot of the focus that we're going to be showing today in the slides is going to be on that placido base, that original topography that we're talking about. And then if you wanted to get information, more 3D information, you can have units that take what are now in the category of tomography. So you're effectively looking at the posterior and anterior aspects of the cornea shape, but getting it in a 3D effect. So if we can go on to the next slide, we'll talk about how best to capture our topography images. I think she's muted. There we
now
go.
It's okay. Yes, I have voice.
Yes.
Now? Okay. Hi, everyone. I am Patricia Flores. Before I start my part, I want to say thank you, Daddy, Mindy, for the invitation, and also say thank you for Steffi, because it's a great college, and this is amazing opportunity to talking about contact lenses, fitting, our passion in contactology. So my part is talking about how some tips to capture an optimal topography image. We think about maybe this is an old issue, but it's not the reality. It's an actual topic, because if we think about to try to interpret the exam from the patient, and maybe try to use this exam for try to do have a success in our fitting contact lenses, we have to be very sure first about the exam is excellent, is precise. Because if not, we don't have to use this exact exam for our fitting contact lens. So if we can review some tips from the reference, from Eve, from Randy, from Lynette, in this year in September 2020, remember for the ECPs about 9 tips for capture an optimal topography image. If I start, I want to remember to you about we need to invest in a corneal topography if we want to work in irregular cornea or customized subcontact lenses. And all the time we not clear about if I want to buy a Medmont, if I want to buy an Elite or Keratograph IM or Trimap. But all these devices, the most important thing is about the optics, because if we don't have a good calibration in each of these devices, we can expect a good result and not precise exam. So the second tip is work in a dark environment. The plastic disc depends about the light from the cornea, reflects from the cornea. But if we have an external light, like a window or another external factor, maybe this can disturb the image. And then we cannot have a good result from our topography image. The third tip, very important, is about the tear film. We need to stimulate and motivate our patient to blink before the exam. But sometimes we give the order the patient, he has to blink, but maybe blink after take the exam. So we have to be very systematic for the instruction we give our patients. If we don't have a good tear film homogeneous on the cornea of the patient, we can use some artificial, no viscous, artificial tear drops for try to improve the surface and take a good exam. We know about, we have some tools in the corneal topography, and we can help to try to decide which exam is the best or not. The quality exams give me the chance to selection about the optimal exam I want to interpret in the next step. We need to take an exam very quickly because we need to optimize my time. And maybe the corneal topography is the most important tools in the fitting contact lens practice. And this corneal topography give me the chance to take very quickly the exam. But this quick exam has to be very precise, has to be complete exam, has to be symmetric exam. And for this reason, the recommendation is not only take one, maybe 1, 2, 3, or 4 exams, and then compare about there exists similitude, is similar, these 4 exams I take. Aim for symmetry. All the time when I take an exam, I have to decide this exam will be a normal or not normal or irregular cornea. So the first step after take the exam, I have to see all the background. I have to see the index, I have to see the meridian, I have to see the color, the scale, and decide this cornea is symmetric or not. It's very important to try to tell the patient about he has to look straight on the device and maybe in the more little or small cycle in the center of the corneal topography. In the majority of this device, the color is yellow or red. So the geometrical center maps is very important to try to make very success and optimal topography image. need more information about the surface corneal surface. So we need to not only buy a corneal topography, we have to know how I can use the corneal topography. Ask the patient about the blink, then he has to open, very open the eyes, and the 8th lid has to be open too. With all these kind of tips, I try to make sure to have an optimal topography image. And the last one, this tool has also some index to assist in the data assessment. So here we have 9 tips very quickly, but very efficient to try to optimize my time, and I make sure I take an optimal topography image. In the last slide, I'm talking about the importance about the tear film in the corneal topography. Maybe until a few years ago, the most traditional test to take a measure about the tear film quality was the tear breakup time. But right now exists another kind of devices like a corneal topography, MedMon, or Keratograph 5M, where giving information about how is the wetting on the cornea. There exists dry spot or not. So this kind of not invasive method we can show in this slide. In the bottom left, you can see an image from a female woman who has a dry symptomatology. The tear breakup time for this not invasive methodology is 6 seconds. So for this reason, you can see in the center of the eye, blue areas representative about their exist wetting, but very close in the center eyes, you can show about red image. This is tell me about there exists not wetting. In contraposition, in the right image, you can see a man who not has symptomatology for dry eye, and the tear break-up time is 14.5 seconds. So this is a very interesting tools for try to know about how is the quality tear film from my patient. So I try to do a comparison between the traditional methodology for invasive method, the boot, tear break up time, and not invasive methodology like I showed you in the slide before. The first aspect is the economic. Invasive method is very cheaper. Only we need a fluorescent band, we need a slim lamp, we need a yellow filter, blue light, and we need to ask the patient blink and then open their eyes, and I can have the measure, subjective measure. I need to invest more money to try to buy another device for give me this kind of result, but with a not invasive methodology. But the scale changed the positions because the invasive method, we have to use fluorescent installation, and this causes tear destabilization in our tear film. So apologize if my English is not perfect, but the fluorescent causes change the pH in the tear film the patients. So the result is not precise. In contraposition, if we use a non-invasive methodology, we don't need fluorescent installation. So we not change nothing in the tear film of my patients. The third factor is about the repetitivity. In not invasive method is more precise the repeatability inter-observer is high coefficient comparative the poor repeatability from the tear break uptime traditional test. And the last factor is about the sensibility or specificity to relate this test for measure the tear film with patient who has suspect for dry eye. Not invasive methodology has better percent for sensibility and specificity for detect dry eye. All these factors, we have a reference scientific. So maybe I know it's more cheap to use invasive method, but if we want to more precise about the quality of film, we can think about to invest in this kind of devices. So this lecture talking about the corneal topography. First, we're talking about how we can capture an optimal topography image. How the corneal topography helped me to optimize my time in especially contact lens fitting. In the next slide, we're talking about for custom soft contact lenses, multifocal, GP fit corneal topography in hybrid. Maybe the next year we can expand my time to talking about for orthokeratology, but we have very short time for this lecture. About for custom soft contact lenses, the horizontal visible iris diameter is a very important value for the initial design for increase the probability lens fitting will be success. Here we have a research from Professor Pat Caroline, who make an study in 300 consecutive eyes and measure about the AV-AD. The 77% of the patient has horizontal visible AD 11.5 and 12.1 millimeters. However, exists another percentage, a larger percentage, 23% of this eye who has a different values. So for this kind of patient with very smaller corneal diameter or very larger corneal diameter, we need this parameter to try to create a customized soft contact lenses. There exists different ways to measure this kind of parameters: the ruler, corneal topography, slim lamp, or loop. But the reference scientific tell me about how is the difference between the manual and automatic method. Related about the inter-examinator coefficient, how's the repeatability. And the worst value is from the caliper, the ruler, then the video image from the slim lamp, and the most exactly better repeatability come from the automatic device, like a corneal topography. So if I have the HBAD more precise, I can create a more precise custom soft contact lenses, and probably I increase the possibility to have success in my fitting contact lens. The highly visible iris diameter is, if it's precise, I can use some software like simulated for fitting contact lens, and this will be very similar to our fluorogram. So I optimize my time. This is an example I take for Professor Randy Kojima. It made me, he obligated to try to think more about this issue, because we have two images, two different patients, very small area. Yes, because it's a keratometry, like 3 millimeters. We need to imagine this area is equivalent to 3 millimeters, like a keratometry. If I think only with this image, which is more easy or more complex for fit contact lenses, soft or GP lenses, maybe I not can see so many difference. But if I have the possibility to have these devices for corneal topography, I have more information and pass from the 3 millimeters to maybe 10 or 12 millimeters. And now I can say about the right image is limbus astigmatic, and maybe it's more complex to has a success, the fitting. In contraposition, in the left image, we can solve an astigmatic too, but apical astigmatic. So it's more easy to fit. The market for contact lenses is growing every year, but we have a very big problem, the dropout in our patients. Many years we have the same principal causes for dropout, and this is discomfort. For these causes, all the company expend too much money to try to invest and do some research to try to find the best material and try to reduce the dropout in our practice. Before, maybe 2 years ago, I read some research to try to relate about the wetting in vitro. In vitro measure about the wetting on the soft contact lenses is related with the comfort. But now we know about some reference actually, like these 4 experiments, 4 studies, suggest there is a poor correlation between the contact angle for surface drop for wetting on the contact lens in vitro related with the eye comfort. So this indicated about the in vitro medition on when I have the brochure from my product. I am very worried about the contact angle wetting of the soft contact lenses. This is not a good indicator to tell me about if my patient will be have or not good comfort or not. In contraposition, some corneal topographers give me information about how is the wetting on the soft contact lenses in the patients. And this parameter show more related with the consort, with the subjective comfort in the patient, in the user. In the left record, we can see a patient who has poor wetting. We can show in very short time blue areas in the center of the eyes, appear some red areas, dry spot. After put an artificial drop out, artificial tear film, the situation changed completely. This is more stable wetting, acceptable wetting, and the comfort in this patient improved. From a word from Randy, you can show in the superior image the contact lens 1, and the inferior image you can see the other material, other commercial contact lens in the same patient in the same eye. You can see in this slide, in the contact lens 1, after 6 seconds, the wetting on the soft contact lenses is poor. But if I change the material, I can improve that. How I know that? Because after the same 6 seconds in the same patient, in the same eye, I don't have any dry spot. I have a still uniform wetting, I still blue area. Tell me about the wetting on the soft contact lenses is good. So when I have a patient in my consult and he is very motivated to use contact lenses, I have to remember first me about the success is not only for the plastic, is for the plastic and the interaction from this plastic with the patient eye. So if I have this kind of machine for giving information, how is the wetting on the surface corneal the patient, can I optimize my time and maybe have success more fast? Now multifocal, Steffi.
To our next clinical situation. And I can't help but always think about if anybody in the audience here has listened to a lecture by one of my mentors, Craig Norman, and he does presbyopia lectures. He always talks about how he describes presbyopia to his patients, saying that presbyopia is a time in your life where your vision sucks. And that's how he starts off. And you know, there's a certain amount of accuracy to that, because what we know in all of the knowledge and all of the technology that we have advanced to this day, we still have dissatisfaction with this modality of the lens. So if we take a look at it, for example, in this image here on the left, this is a soft lens that's resting on a patient's eye. It's a center distance multifocal lens. And what you're seeing here is that you have, it looks relatively behind the occlusive slit lamp. I would grade this, and I'm sure many of us would grade this as the patient is not a video here, but it's a centered lens, well centered on eye. There's good corneal coverage. I highlighted with these arrows here on the screen to show that the arrows in the little triangle heads in blue, that there is a slight temporal decentration of this particular lens. The use of topography over top multifocal lenses is ideal because it gives the chance, and these are tangential maps, so looking at shape differences on the surface of the eye, we can see that we can actually identify where the center of that optic is in that particular lens in relation to where the outer optic is, because you are effectively looking at the change in power. And so if you're looking on the right-hand image with the topography, that white plus, if we can go to the next slide. The next slide shows us that we have our visual axis is defined right in the center. So that's where we ask the patient to look straight ahead when they're looking through their topographer unit. And that aligns up in the center. That doesn't always add up, where if you look at the black circle on the image on your left, the black circle is identifying the pupil, where the center of that with the black cross is looking at the optical center. So we know that there is always this difference between the optical axis and the visual axis, and that's our angle lambda, sorry, angle kappa. And when we then incorporate that natural deviation that our optical system inherently has, and we add to it multifocal optics on top, you can see that the center of the optic here in that lens that looked ever so slightly decentered actually is temporal in this eye here. You can see that it's temporally located at another component into the optical noise, so to speak. And if we take a look and extrapolate and put that lens on eye, you can see that where the visual axis would stand out, where the optical axis would be, and where the center of the optics, in this case, this is the near optics here, would have the displacement or what we call a mismatch. You can clearly see there's this triangle of mismatch here. Now, if we go to the next slide, we wanted to see what would be the benefit in better aligning. If we could better align those optics with the visual axis, could we improve the quality of vision for patients? The study here was carried out at the Michigan College of Optometry, and we were looking at specifically decentering optics in hyoxyphilcon D lenses. And what we did was we had, if we can go to the next slide, I'll talk about the methodology. We had 21 subjects that were able to complete the study. And what was carried out was that they had a diagnostic soft lens fit on eye. And then it was a soft multifocal lens, and we measured the mismatch of all the diagnostic lenses on eye. And then we ordered them based on the diagnostic for their power, 0 offset. So the near optics stayed where the lens would theoretically be, so in the center of the lens. And then we had a 1 millimeter nasal decentration of the optics. Why nasal? Because most of these, in fact, all of these lenses, when we had the diagnostic lens on eye, all of them had that slight temporal decentration of the optics, 100%. Not a single lens had the optics centered over the visual axis. So we had a 100% decentration of the near optics in the diagnostic lenses. When we ordered the lenses, we had the 1 millimeter nasal offset, and then we had the centered optics as well. And so the whole point was to have the patient use both lenses in different clinical scenarios. They were unknown to which scenario they were wearing, and we tested them with very real world situations. So we had them look at a email on a smartphone at the normal light sensation on it. So not the dark mode on the phone, but the light mode. So you could see there's different font on the phone, there's different colors, different sizes, and their ability, not just this is a stationary image, but their ability to scroll and still be able to track the letters is also important without the font smearing. Also had them read a magazine as well, different color font, different color background. And then we had them look at a prescription bottle. And so if we can go to the next slide, out of the 21 subjects that were recruited in all the 42 eyes, we can continue and just populate this slide here. We had 20 subjects complete, and so all of them are going from emergent presbyopes into mature presbyopes at this point. A variety of different prescriptions we were able, because we could put a toric prescription into these lenses. Average size pupils, and then they had average size HVID. If you were going ahead with the next slide there, yes, okay, the next point. And so what we were looking at was the subjective responses. So in addition to measuring Snellen acuity, we looked at those real world scenarios and scales. Surveys were used in order to grade subjective findings of visual quality. And so when we had, this is an example now of the mismatch, you can see in the left eye, if there is no offset, so the lens is made with the optics, the near optics in the center, you can see in this one example on the top line, there is almost a full 1 millimeter mismatch in the temporal direction between where the visual axis is and where the near optics is. And this is, when it says 0 offset, this is exactly what we found in most of our diagnostic lenses. If you look at the lens that was designed for the patient with the 1 millimeter offset, you're looking at now still an offset. It's not on the temporal side though, but it's a 0.32 millimeter mismatch in the nasal. So all of these lenses were not customized with the mismatch. It was all set for a 1 millimeter mismatch. Now, some of those eyes to begin with, like I said, in the example you see on the left eye in the 0 offset, when it's only 0.77, a mismatch in the temporal direction, theoretically, we could have quantified and only done 0.77 for this particular patient, but then that is taking away from it's too specific for the particular purposes of the study. So it wasn't something we wanted to control for. And so the 1 millimeter offset, you can see how it better aligns the optics with the center. And then that's something you can notice too on the lower line is another example where we had in the 0 offset, it was 0.83 millimeter offset between where that green center is in the lens and where the visual access center is in the middle in the white cross. And then if we have the 1 millimeter offset lens, you can see how that green has been brought closer to the visual axis, and in this case has moved on over to the nasal side. So what were the implications now of putting these lenses and shifting the optics? And so what we found was that, oh, sorry, can we go back? I was just trying to move my, I just want to talk about the bottom paragraph. So the average offset for the 0 offset lenses, so where we did not move the optics, was 0.64 millimeters. And so it was all in the temporal direction. And in the 1 millimeter offset for the right eye, you can see in the subject population that we had, it was very close to being right in the center of the visual axis. For the left eye, we had them slightly deviated from the visual axis in the 1 millimeter offset, but the 0 offset, you can see similarly in the temporal direction, 0.78 millimeters. So it is a significant amount of decentration or mismatch between where that near optic should be and where the visual axis is. And this was found in all of our offset patients. So what does that mean for us in practice? If we can now go to the next slide. So the key findings from this study was that there was both a statistically significant difference and a clinically significant difference in the patients that had the 1 millimeter offset design lens for near viewing tasks. Ironically, there was no change, statistical change in the distance viewing, only in the near viewing. And what subjects were reporting were that and when I say that there was a statistically and a clinically significant difference, it actually only added up to 1 Snellen line of acuity in the near reading change. But we found that there were these were some of the comments from the patient letters. They had a less of a 3D effect that sometimes you hear patients talk about, the double letters that they have, the shadows. I know I hear that a lot of time from my patients. And they don't see a halo or glare around the letters anymore. So while it didn't solve, crack the presbyopia code, we know that if we can better align the optics, we can subjectively improve quality of vision for patients. And that's something that we can use topography to take that application of a multifocal lens to the next level and see how can we better align these two to improve the quality of vision for our patients. Because we know based on this study, it has shown positive results.
Mm-hmm. Okay. Yes, can you hear me? Yes, Daddy?
Yes, yes.
Yeah, perfect. So continue with the agenda, how we can use for optimize our work with corneal topography and GP fitting contact lenses. So there exists some research from professors like Pat or Randy, another one too, talking about the importance, not only about the axial map, about the elevation map, because this map gives me the true shape of the cornea. And if I have a good capture from this elevation map, give me information about how will be the fluorescent pattern. Like you can see in this image, in an elevation map and a patient who has irregular cornea, the red areas, it means the place where I expect the contact lenses touch the cornea. In contraposition, in the blue areas in the low, here I mark with my mouth, you can see this is representative where the contact lens has more separation with the cornea, more clearance between the lenses and the cornea, more pull fluorescein pattern. So based on this concept, the conclusion for this poster and research was related about if the patient has the difference between the more depression area in the elevation map comparative with the more high position elevation is 350 microns or less. The corneal elevation difference along the large arch meridian has an 88.2% chance to have success with the corneal GP lenses. For the other hand, if we have more than 350 microns, we don't have to play with the corneal GP lenses. We have to pass to the other step, is scleral contact lenses. This is a patient from my consult in Chile who has irregular cornea keratoconus, and the difference between the depression and the elevation is less than 350 microns. So I decided to put in this patient, for the recommendation from this research, a corneal GP lenses for keratoconus. And the result is that you can see in this video. So I have a patient who has ectasia. I have fit contact lenses, corneal contact lenses, and really optimizes my time for do this work. Other example, I have a patient who also has irregular cornea. You can see in the tangential map about the regularity, but I think maybe it's not too much, but the elevation map, the difference is more than 350 micron. The difference from the depression and the elevation point is 690 microns. So if I do the simulation with the corneal topography, the device give me the alert about it's not good design, it's not good choice to fit GP corneal contact lenses in the patient. So I had to use another kind of design like a scleral contact lenses.
So if we want to take it one step further now, and we know that with placido disc topography, we can't really get an idea of what's going on the scleral surface. The useful information past that 8mm cord, sometimes depending on how wide the eye is open and the ability to stitch some of the information together in a placido disc-based topography or a different form of topography gives us adequate information, but not of the just of the cornea, not into the scleral surface. In this modern era now, we're into looking at corneal scleral topography, and specifically we're using structured light and having the eyes in various positions of gaze to gain a better understanding of what the eye shape is, creating a 3D model, not just of the corneal surface, but of the scleral surface as well. And why is this important is because when it comes to scleral lenses, we are now not fitting based on base curve. We know that it's sagittal height of the eye that's important to match to the depth of the lens of choice. And so with some of these newer units, which we're not going to get into too much detail, but it's for the purposes of completing this conversation here this morning, that we have lenses that can be produced directly from the instrumentation itself. Now, as we are all within, regardless of where you are in the world and your highs and lows for COVID, a lot of talk is now on empirical fitting of contact lenses. Patricia just went over empirical fitting of corneal GP lenses. Now, the question is, can we do it for scleral lenses as well? And there's a certain amount of component, and as well with this particular instrumentation, you still have to put a lens on eye in order to gain information about the power of the lens that you want to put on the lens. But there is still the application for less diagnostic fitting and more empirical based fitting. Here, if we can go to the next slide, here's an example of a lens on eye that was fit according to manufacturer recommendations. You can see that's just a diagnostic on eye. We know of the typical inferior decentration of scleral lenses on eye. The image in the middle is a diagnostic lens that was fit in. We have the lens that's received and it was dispensed. You can see along the horizontal meridian, we still have some congestion of the vessels that are there. But if we look at the lens on the right side, this is the cornea lens that is dispensed based on the, specifically, this is the SMAP 3D. And you can see there's some alleviation of those vessels. Now, when you have these instrumentation, what they really do is help you improve your efficiency on getting the lens on eye and understanding the scleral curvature so you can better fit right on in the initial experience. So we're going to end off today's talk with hybrid lens fitting. And after working a lot with hybrid lenses on eyes, it's important to remember a couple of things about this modality. So depending on the type of lenses that you work with, here in North America, there's only one specific one that we do work with. And you can't make modifications to the gas permeable center or the size of the soft skirt. So when you have different eye shapes, in this case, we've talked about the implications of HVID on soft lens fitting. The same applies for hybrid lens fitting as well. You can see how well centered, if we can click to the next command, you'll see that you have an outline of where the lens is sitting on eye. To see if we can click next. And then we have, you can see that the lens that's sitting on the image on the right, that is an HVID. It's an eye size of close to 12 millimeters, it's 12.2. The one on the left is 10.2. And so what happens is that this will affect the centration of the lens on eye. And ultimately what we what our biggest concerns are sometimes with the hybrid lens modality is we don't want it to become immobile towards the end of the day. And that's exactly what can happen when you have a lens that's too decentered on the eye, as in the right image. If we can go to the next slide, you can see that this variability of fit, if you're looking at the image on the left, which is a smaller eye size and it's more central, you have that decentered lens on the right side. In addition to the fact that it may become immobile towards the end of the day, if we go to the next slide, you can see if you take topography over top, you will have the aberrations from astigmatism that come in. You'll see from the topographies that are about to come up next that the poorly centered lens actually induce over a diopter, almost a diopter here of a corneal astigmatism. And so what that does is that will not only make the lens become inefficient because it's moving, but also it will decrease quality of vision. Now, you have to be careful because sometimes what happens is, sorry, if we go back one slide, you have to be careful with these lenses because if you have an eye size that's too big, you sometimes need to fit a skirt curve that's a little steeper to accompany for the fact that that lens may just want to go in a downward position and settle there. And so you can go to a steeper skirt curve in order to lift it up. And that is something that if you take a look at the eye size to begin with and understand that a hybrid lens will perform differently on different eyes, even though the actual metrics in the lens itself, those parameters don't change. You can make modifications in how you fit it based on the eye that you're fitting it on. In addition to looking at how we fit the lenses on eye, in the next slide, we can also apply in many of the other lens modalities that we have at our disposal right now, you can apply a surface coating. And specifically, it's the HydroPEG coating to improve the wettability of the lenses on eye. So these are sequential measurements of topography, so non-invasive tear breakup that we were talking about earlier. And you can see in this particular patient who has a hybrid lens on, and in the baseline visit, that's the eye without a lens on, you can see that there's a decreased tear breakup time. And then with the coating applied to it, in this particular incident, you can see that at the dispense visit and at the 1-week follow-up, there's a significant improvement in the surface wetting of the lenses. So what's key in this particular setup here is that not only could you use topography to initially help in your diagnosis, but you can use it for your management and education for a patient so they can understand what it is, like what was the skilled component to their fit and how did that affect their performance overall. And so they may say to you, oh, the lens feels much better, or the eye feels less dry, maybe now compared to a previous modality, but now they can see and monitor over time how that lens did perform. And it just gives them a better understanding of what's going on. If we look into the next slide now, you can see that I'm sorry, I'm going to go back one more. Yes, if we look at this one, this particular patient, the lens, this patient here was actually not symptomatic. Their tear layer was perfectly fine at the very beginning. And in this case, with hybrid lenses were coated with the coating to improve wettability. In this particular patient, the wettability did not improve. So I do find that it's important to keep the surface coating of the hybrid lenses in your back pocket, not necessarily that you would start off right away from, because when you have a patient that presents to you with a new lens modality and they do have that experience of dryness, I think it's important to have that option to give them something that can make it better as opposed to starting with it right away. And that's what we found in looking at a series of subjects wearing hybrid lenses that were coated and hybrid lenses that were not coated. One of those subjects you'll see in the next video had experienced dryness of the hybrid lens on eye and wasn't really understanding why previous lens modalities weren't working well for her. And you can see it is drying up, but the issue here is just incomplete blink. And that's something that you can help explain to the patient, that it's not necessarily that the lens modality is drying up. You may have to change how you are effectively, whether you're incorporating blinking exercises, you are educating the patient that it's not necessarily the lens that's not performing properly. We have to address the situation, all components of the ocular environment properly, and the positioning of the lids in order to be the most successful we can with our contact lens fitting. In the next example, you'll see of a lens that is truly breaking up in time. As the patient blinks, you can see areas where if you look in the reflection of the placido rings, you can see that especially in that lower nasal component there, that there is decreased tear breakup time. And again, you can show this to your patient. What that leads to is an increase in discomfort of contact lens wear. And for what we are trying to do with this entire presentation here is say that there are steps we can take to make sure that we don't lead to patients decreasing wear time, which ultimately means contact lens dropout. So, a lot of the studies, especially in the soft contact lens realm, show that at least 25% to a third of all our patients will drop out of contact lens wear. And we've come so far with instrumentation, with materials, with technology to help improve the wetting of these lenses. But we still find that we're not, it's not a one size fit all, one answer fit all to all these patients. Every patient's going to present with a unique scenario. So that wraps up here today. If we can move into our summary slide. Ultimately, as Patricia said earlier too, we do believe, we're strongly arguing for it, that corneal topography is the most important tool in your practice, especially if you're going to do contact lens fitting. It helps build the story of the surface that you're going to put now a material on, whether it's a soft lens material, a hybrid, a corneal GP, a scleral lens, and then helps you to understand which best avenue to go on to fit that particular patient. And ultimately, if it can increase the efficiency of your fits, you're going to decrease chair time and then ultimately increase revenue. And so right now, what's really great to be having the ability to have a corneal topographer. We didn't get into some of the additional features that a lot of the modern day topographers do have, but they can bring much more reward to your practice, not just in the contact lens realm, but also spilling over into other areas.
Yeah. Daddy, I have opened my microphone.
Yes, you have it open.
Yeah. Ah, okay. I am muted. I want to add about the Stephanie slide. In the past, we think about the corneal topography for especially contact lenses. And she showed, I am very proud for her, about a study about the multifocal soft contact lenses. Now I want to relate about the clinical and commercial. Right now, scleral contact lenses, hybrid, especially GP lenses, we have a lot of market, but the most important market in contact lens right now is disposable contact lenses, okay? First, spheric contact lenses, toric contact lenses, and multifocal. And the last one, the multifocal, is the most complex design exists right now for the traditional soft contact lenses. And we have a big market. We have a many patients who has presbyopic and they need multifocal soft contact lenses. But why, from the totally percentage of soft contact lenses fitting, why the multifocal is only a few part the cake? Why? Why, if the Johnson & Johnson, Bausch, Menicon, Cooper invest too much money to try to create the best contact lenses multifocal, why we still have a little market? And the reason maybe start from the work with Stephanie, because with these kind of devices, we know with more precise measure about the decenter optics for the multifocal. And this is not for irregular cornea. This is for traditional soft contact lenses. So we have to keep in mind about to try to have or invest in this kind of devices like a corneal topography for plastic disc or another kind of strategy. We can use not only for irregular cornea, not only for orthokeratology, also for our traditional disposable soft contact lenses, optimizing my time and make more possibility to have success in our fitting. So I don't know if you have with some questions or comment.
Yes, thank you so much, Patricia and Stephanie, for this very clear and very informative presentation. I learned a lot from your presentation. We have some questions. Karen, please.
Hi. Well, first of all, Patricia and Stephanie, congratulations. What an amazing way to end this whole summit meeting, which Daddy and Mindy, kudos. What an amazing run. This was a great lecture. I also learned quite a bit. I actually have a couple of questions for both speakers. I'm going to start with you, Patricia. When you show the non-invasive capture in the Metmon for the tear breakup time, if you were to put artificial tears on a patient to try to improve the wettability, how soon can you see an improvement in that capture? And then a lead off to that question is that modality in the Metmon pretty accurate, or is it prone to artifacts? That's the question for you. And then for Stephanie, what Patricia just said, I was actually going to ask you about that because it was so interesting to see your research with multifocal soft lenses. And my question to you was, are you able to order offset optics for most multifocal soft contact lenses today, or just with a few? And if it's just with a few, which are those? So that was it, but congratulations, ladies. Amazing. Thank you.
I am very proud you stay in this lecture, Dr. Carrasquillo, because you are the big Carrasquillo, you know that. So about your question, I not want to speak only about the Medmont system, maybe the Medmont and Keratograph 5M2. This kind of tool, not invasive tool, right now is the most strong test from the TF of Tear Film Ocular Surface Commission, who made the law about which test we can use for detect dry eye patients. And we put in the past about the tear breaker time and use this kind of new methodology. As for your question about the effect I see when I put artificial tears on the corneal patient is immediately. But this is a beautiful word, commercial word, because improve immediately, but this is not the most important. The most important thing is immediately change, yes, but how many times keep stable the tear film, the wetting on the soft contact lenses? This is the most important question. And for this second question, I don't know the answer, because it's not only depend about the artificial tear film, depends about the biocompatibility with the artificial and the eye the patients, and the pH from the tear film and the contact lenses. But we grow right now in this issue. I feel better with my patient because I saw the result. When I have to decide if I put an silicone hydrogel or only EMA, this kind of tool helped me to take the decision and optimizing my time. And your second question was related to
Artifacts. How is it?
Artifacts.
Yeah.
Yes. We have material reference scientific here, but maybe I can tell you about only my experience, but doesn't exist like too many topics in contactology, specialty contactology. We don't have too many research about this issue. So my experience is not give me too much artifact, but this is my experience only. We can see in the future.
Yeah, I was going to, just to jump on about the artifact. I think there's a certain learning curve for, because we had it incorporated into practice here, and in training staff, I found that even if different staff weren't doing it properly, or they had the patient blinking at a different time, it may not be necessarily be captured the same way, and then the value would be different. But I think it's important to have the way that you're doing it to be accurate, and then that way, or the way that you're doing it to be the same, and that can help increase the reproducibility. Now, whether or not that helps to get rid of artifact or completely remove the artifact, I equally too, I don't think we know enough. I think we know that we get a value and we see the value, and we can then clinically extrapolate information from that value. Yeah. But I think maybe a lot of it is like gross interpretation of, dry versus non-dry, like wetting. And then the numerics can help with that. So I think it's still developing in its use from my experience too. Karen, your question regarding, thank you as well, Dr. Carrasquillo, for your question and being here with us today. Regarding the manufacturing of offset optics. So this particular, no proprietary or financial interest on my end, I just have to say that. This was a study carried out through the university. So this is Specialized. Specialized was making the offset optics, and they are still giving them out. And I remember we sat down and had a conversation. If you know, there was so much of a significant improvement in quality of vision, why not start off with offset optics to begin with? And I don't think it has. So this is only in the custom soft modality. It hasn't taken off completely yet. And I do know that we also discussed not just because what we know about the visual access being decentered, not nasally also, but superiorly. And we can see that also in some of our scleral lens modalities. We see that that decentration now happening, not just we had a 1 millimeter offset nasal decentration, but the possibility of now moving it not just in the horizontal meridian, but moving it in the vertical meridian as well. So the aspect of having it completely commercialized is not there yet, to my knowledge. I do know that it is still available for order.
Yeah, very interesting. I have some comments to both of you about the corneal topography and specialty contact lenses. So we have the general belief that when fitting scleral lenses, the topography over the cornea is not very important. In my experience, and what I do a lot is definitely to perform a topography, not only to understand what cornea I am dealing with, but also because, as you said, Patricia, the elevation map is very important because it gives you the fluorescein pattern and the pooling of the fluorescein in the corneal area. How to use this information? Well, I personally design toric corneal zones, but in the commercial designs, you can decide to make quadrant-specific design, which includes also the limbal area personalized, and also a toric limbal zone, which some commercial design provide. This one factor. The second factor is the corneal sag. Some corneal topography can provide you the corneal sagittal height at a specific chord, and using the sag factor table, you can understand how much the first lens, the first diagnostic lens you need with the corneal, the sag of this lens, how much it should be. So it's time saving. The third thing is the topography over the scleral lens, also over a corneal lens, to detect lens flexure. This is very important to detect the lens flexure, and I think that we are not using corneal topography so much to understand the aberrations of the cornea. We have these data in all the topographer, and I think, I don't know, I want to hear your opinion. What about the aberration, the coma, the spherical aberrations that the topography gives us? We are still not using them enough.
I totally agree with you about the utility we have with some maps in our fitting, like elevation map. I think it's very important if we have very precise commercial designs to try to have more customized our fitting contact lenses. If I'm talking about GP corneal contact lenses, I wish to be your magic to try to design our design for GP contact lenses, but I not have this magic like you, Daddy. So I depends more from the commercial design. I buy to more precise design. The quantity vision I can improve in my fitting contact lenses. The quality vision I try to improve, but sometimes it's difficult because the aberrations. There exist many patients, not many, but maybe a few percentage very exigent patients, I don't like it, who tell me about, I can read in distance, but in the night, I don't have a good quality visions. And we have to know about, if I put an scleral contact lenses in the irregular cornea, I can resolve some kind of aberration, but then can appear another one. Maybe can I resolve the coma, but maybe I not compensate the trefoil, you know? So the aberration, I think is a topic the company has to work more, because we only think, right now, we think about to customize the anatomy scleral contact lenses, but not about the quality vision, the quality life, you know? So we can grow step by step. And finally, maybe the commercial manufacturer kill me, but another issue very important the company has to improve is about, if I want to work for especially contact lenses, I want the topography give me everything. The most precise measure for the cornea, for ortho-K, for GP contact lenses. Give me information about the wedding on the soft contact lenses, and also give me information about the limbal and scleral. But right now, you have to choose from your two men's. Do you want the most precise corneal topography, or do you want to a scleral topographer? But you can have the both, the best repetitivity and the best measure. So, at this point, the company has to be very honest with the all ECP. The corneal topography is a great tool, but right now we can expect about the most precise corneal topography in all these sequences, corneal and limbal and scleral in the same time.
Yeah, definitely.
I want to add on, Daddy, to your original point about saying that maybe it's not as, if you're fitting scleral lenses and you're mainly fitting to the sagittal height of the eye, is it even important to take a topography? I think it's really important to, one, get a baseline idea of what is going on with that eye, because that topography can change with patients. Not that you're going to get necessarily warpage because a lens is sitting on the eye, but just because a lens is sandwiched in between the back surface of the scleral lens, the eye is sandwiched between the back surface of the scleral lens, and that lens is on the eye, 8 to 10 to 12 hours a day for some patients. We know that we'd like to get a nice clean baseline image of what is going on. Not necessarily that you will use it, you may use it in your fitting, but even if you don't, you still want to monitor patients for progression, which if you don't take topography, you don't have that ability to do so. It's important to still be measuring as part of management. I think that's something that we tend to forget, depending on what's going on with the patient. And if you don't have anything to compare it to, like how we take difference maps, we can't really see what the difference was if we don't have a record of it.
Okay. One final question for you, Stephanie, from the chat. It was referred to the multifocal contact lenses. How were you grading, quantifying their visual acuity with these real-life targets?
So in addition to quantitatively using Snellen acuity, qualitatively we were using scales. So it was just a scale from, as non-scientific as this portion could be, it was scales of 1 to 10 and how they would grade their vision. So they were in one situation where they knew what was best, better, could be, and third tier on how the images were showing up on the specific scenario. So if they were looking at the cell phone and they had a certain level of vision, if 10 is the best vision and 1 being the poorest vision, what would you rate it as? And there was a week in between them wearing the offset and the non-offset, so you're not going to remember that number in that one time. And so it still gives us an idea of a comparison. And so mainly it's a lot of those aha moments, like in the subjective lines of, you know, it's the smear, it's the shadow. Those are the things that we hear so many people complain about, not just in multifocal optics, but also it goes back to your component about aberrations. We can have like the best scleral lens fit on eye, and the patient is just bothered by that shadow that's right there, you know. And so I do think the topography helps in many aspects to tie that story all together, in addition to understanding how the eye is shaped.
So we are largely out of time. Thank you so much, Stephanie and Patricia, for this excellent lecture. We definitely ended this series of meetings with an excellent session, and thank you so much. So as I anticipated in the beginning of this session, we are celebrating a professional who has attended all our meetings. So this person is Dr. Kyriakos Telamitsi from Cyprus. Congratulations, Dr. Telamitsi, from the Summit of Specialty Contact Lenses. So please join me in congratulating Dr. Kyriakos.
Good afternoon.
Congratulations.
Good afternoon from Cyprus.
Yeah, so Dr. Telamitsi, Kyriakos, we truly appreciate you for joining all the virtual session of the Summit 2020. Every session you were there participating to this session, and as a recognition, we would like to provide you this award and also to waive your registration fees for the next in-person meeting, which we hope would be very soon. Definitely, we hope to get together again very soon in person. And now we have finished. Kyriakos.
Well, I want to say thank you to the committee. Thank you to Tati and Mindy. And today's subject was excellent. And I want Stephanie and Patricia to go to next topics and get deeper to these topographers, and we want more true stories.
We only bring you the truth. Thank you.
Okay, thank you.
Okay, so thank you everyone, and thank you for joining this session. Thank you for everyone who joined the other session as well, and we truly hope that we will be meeting in person maybe next year, maybe in 2 years. We still don't know because these are so uncertain times. So please stay safe and see you in virtual meetings around the world.
Congratulations, Daddy.
Thank you. Thank you. Congratulations, Daddy and Mindy.
Congratulations.
Thank you.
Excellent job.
Ciao, ciao.
Bye. Bye, everyone.
Bye.